Bismillahirrahmanirrahim. And quote for the day is truth has come and falsehood has vanished. Indeed, falsehood is ever bound to vanish. This is an ayat from Holy Quran. The topic for today's presentation is scabies. I am Dr. Ayesha Amin, PGR of FCPS Community Medicine at Institute of Public Health, and I will be presenting this under the kind supervision of my supervisor and teacher, Professor Dr. Saira Afzal, who is the Dean of IPH Lahore. The learning outlines for today's presentation is introduction, epidemiological determinants, chain of transmission and communicability, clinical manifestation of scabies, management, levels of prevention, recent advances, and multiple choice questions. Learning outcome. By the end of this presentation, the participant will be able to describe the epidemiological determinants of scabies, clinical feature of scabies, national and global burden in its prevention strategies, and to be able to answer the MCQs. Introduction. Scabies is a highly contagious parasitic skin infection which is caused by the mite Sarcoptes scabies. It is a neglected tropical disease and a major public health problem, particularly in resource limited settings and overcrowded communities. Scabies is one of the commonest dermatological conditions, accounting from a substantial proportion of skin diseases in developing countries. It occurs worldwide, but it's most common in low income tropical areas. Children and older people in resource poor areas are at higher risk. Coming to the epidemiological triad of scabies, we will look all the factors of agent, environment, and host one by one. Agent. The agent for scabies is Sarcoptes scabiei, which is an obligate human ectoparasite. The female mite, it burrows into the stratum corneum layer of the skin. The life cycle is completed into the human skin. The survival of host is about 24 to 72 hours. It causes disease through hypersensitivity reaction to the mite, eggs, and faces of the Sarcoptes scabiei. Host, all age groups are effective. It is the people who are at the higher risk of getting scabies are children, elderly, and immunocompromised individual, people who are malnourished, and people suffering from HIV. Overcrowded living conditions, poor personal hygiene, close physical contact, as in household members and sexual partners, and institutionalized population like hostels, prisons, and nursing homes. The environmental factors: overcrowding, poor sanitation, poverty and low socioeconomic status, limited access to healthcare, cold climate, which offers survival to the mite for a longer time, institutional settings, as we have already discussed, like schools, daycares, centers, hospitals, and shelters, and natural calamities like post floods. The incidence of scabies usually increases. Incubation period: in people who have never had scabies, it will take about 4 to 6 weeks for symptoms to begin. During this period, the infested person can spread scabies. In people who have previously been infested with scabies and are exposed again, symptom can begin within 1 to 4 days. Period of communicability: scabies mite is an ectoparasite, and exposed individual is potentially immediately infectious to others even in the absence of symptoms. Cases are communicable from the time of infestation until the mites and eggs are completely destroyed by the treatment. Transmission: humans are the source of infestations. Animals do not spread human scabies. Prolonged direct skin to skin contact, sexual contact, household contacts, and caregiver to the patient contact. Indirect transmission often occurs through fomites like cloths, bedding, and towels, and institutional spreads again through overcrowded areas such as schools, hostel, prisons, nursing home, and hospitals. They all contribute to the transmission of scabies. Pathogenesis: the female ectoparasite, that is Sarcoptes scabiei, might penetrate the human stratum corneum layer of the skin. The mite forms burrows and lays eggs in the superficial layer of the skin. Eggs hatch into the larva, then nymphs and adult mites. The life cycle completes on the human skin. The mite products eggs, saliva, feces, kaibala. They act as an antigen. Hosts develop a delayed hypersensitivity type 4 reaction. It leads to intense pruritus, which worsens at night. Scratching causes excoriations and skin barrier breaks. Secondary bacterial infections like impetigo and cellulitis may occur. In immunocompromised patient, massive infestation led to crusted scabies. We will look into the detail of crusted scabies later. The common sites for scabies in adults and toddlers. In adults, the common sites are wrist, elbow, armpit, area between the fingers that are finger webs, and waist. Scabies in babies and toddlers commonly occurs at head, face, necks, hands, and soles of the feet. The clinical feature, the scabies is characterized by intense pruritus, which worsens at night. There is papule, vesicle, or nodular rash on the fingers, wrists, arm, legs, and belt area. There are burrows, which are thin serpentinous lines on the skin. There are inflamed bumps on male genitals and female breast. There are excoriations due to scratching, and secondary bacterial infections, impetigo, pustules, and cellulitis may occur. So there is intense itching, which is especially at night. There are rashes that are appear as small red bumps or blisters on the skin. There are thin, irregular burrows, tracks made up of tiny bumps or lines on the skin. Sores caused by scratching, leading to potential secondary infection. Itching and rash may worsen with the time if the scabies is left untreated. Now, the type of scabies, there are following types of scabies. The first is classical or ordinary scabies, which is most common form, and there is intense nocturnal itching. There are burrows and papular rash. Then there is crusted or Norwegian scabies, severe form of scabies with heavy mite load. There are thick crust and scales, minimal or absent itching. It is highly contagious and it is seen in immunocompromised individuals. Nodular scabies. It is a persistent itchy nodules are present in nodular scabies and it is commonly occur over genitalias and axilla. It is due to the hypersensitivity reaction. The other type are infantile scabies, which affects infants and young children. It involves face, scalp, palms, and soles. It is often misdiagnosed and mistreated. Then there is bullous scabies, which is rare and it presents with blister-like lesions and it mimics bullous pemphigoid. Then there is scabies incognito. If the patient or someone is using strong drugs like steroids, which are applied on the scabies rash, the disease usually get masked and the lesions are suppressed. The other type of scabies is animal scabies. The animals are also susceptible to scabies as well. The infected animals that can transmit scabies to the members of household as well. And then there is another type which is known as clean man scabies that is seen in person who bath regularly and are clean. They're generally hygienic, but their lesion are they are usually hard to see in these kind of individual and the itching is minimal. These pictures are showing the lesions of the scabies. We can see that the common sites which are involved in scabies are the finger webs, axillas, genitals, and in infants, it usually occur on the foot and soles of the foot. There are the following complications of the scabies. Number one, there can be secondary bacterial infection like impetigo, cellulitis, or abscesses. There can be a long-term effects on kidney and heart. In kidney, it can lead to the post-streptococcal glomerulonephritis, rheumatic fever, chronic eczema or eczematization. There can be crusted or Norwegian scabies in immunocompromised individual. There is sleep disturbance due to intense nocturnal itching. There are psychological effects of anxiety and social stigma. So, what is crusted or Norwegian scabies? Some immunocompromised elderly, disabled, or debilitated person are at the risk of scare form of scabies, which is called as crusted or Norwegian scabies. Person with crusted scabies have a thick crust of skin that contain large number of scabies mites and eggs. The mites in crusted scabies are not more virulent than in non-crusted scabies. However, they are much more numerous, up to 2 million per patient, because they are infested with large number of mites. Person with crusted scabies are very contagious to other person. In addition to spreading scabies through brief direct skin to skin contact, person with crusted scabies can transmit scabies indirectly by shedding mites that contaminate items such as their clothing, bedding, and furniture. Person with crusted scabies should receive quick and aggressive medical treatment for their infestation to prevent outbreak of scabies. Diagnosis. The diagnosis of scabies is based on the clinical recognition of the typical features of the scabies ectoparasite infestation. The diagnosis of scabies can be supported by the visual imaging techniques such as dermatoscopy or microscopy of skin scrapings from borrows, but this is generally not necessary, especially in high endemic areas. Whenever possible, the diagnosis of scabies should be confirmed by identifying the mite or mite eggs or fecal matter, that is Skybala. This can be done by carefully removing the mite from the end of its burrow using the tip of a needle or by obtaining a skin scraping to examine under a microscope for mites, eggs, or mite fecal matter, that is Skybala. However, a person can be infested even if mites, eggs, or fecal matter cannot be found. Fewer than 10 to 15 mites may be present on an infected person who is otherwise healthy. The treatment of scabies is very important. The mites that cause scabies usually die after 2 to 3 days away from the human skin. So we need to break the contact with the human. Scabies can be treated with the topical creams or oral medication in more severe cases. Itchiness often gets worse for 1 to 2 weeks after treatment starts. The topical options we have, which can be applied over the whole body, include 5% permethrin cream or lotion, 0.5% malathion in aqueous basis, 10 to 25% benzyl benzoate emulsions, and 5 to 10% sulfur ointment. Ivermectin, which is usually taken orally, is also highly effective, but it should not be taken by the pregnant women or children who weigh less than 15 kg. Ivermectin is now included on the WHO essential medicine list for scabies, and a number of suppliers have been WHO pre-qualified. Then we can go for it. Antiseptic or antibiotics are used to treat the bacterial skin infections or impetigo. Wash and dry bedding and clothing that has been in contact with the infested person using hot water and drying in direct sunlight or a hot dryer cycle or dry cleaning. Seal item cannot be washed. The items which cannot be washed, they should be sealed in a plastic bag for a week to help eliminate the mites. Clean and vacuum or sweep rooms after an infested person has been treated, especially for the people with crusted scabies. So again, this diagram is showing the treatment of scabies. So there we have the option of permethrin, ivermectin, and topical ivermectin. The permethrin is the treatment of choice. It is applied from the neck down, usually before bedtime, and left for in about 8 to 14 hours, then showered off in the morning. One application is normally sufficient for the mild infection. For moderate or severe infection, another dose is applied for 17 to 14 days later. It may cause slight irritation on the skin, but the sensation is tolerable. As far as ivermectin is concerned, it is an oral medication. It is often used as a single dose treatment of choice for crusted scabies, and it is often used in combination with the topical agent. And it is given as 200 microgram per kg of body weight. And it should not tested on infants and not recommended for children under 6 years of age. While the topical ivermectin preparations have been found to be effective for scabies in adult and are attractive due to their low cost, ease of preparation, and low toxicity, and there also has been used for sarcopte manage in the which is the veterinary analog for human scabies. So, who should be treated for scabies? A treatment, it does not kill the parasite's egg, and treatment should be repeated to kill newly hatched mice. People do not experience symptoms in the early stage of infestation to reduce spread. All people in the household, they should be treated even if they do not have the symptoms. Anyone who is diagnosed with scabies, as well as his or her sexual partners and other contacts who had prolonged skin to skin contact with the infested person, should be treated. Treatment is recommended for the members of the same household as the person with scabies. All persons should be treated at the same time to prevent reinfestation. Retreatment may be necessary if itching continues more than 2 to 4 weeks after treatment, or if new burrows or rash continue to appear. Coming to the prevention of scabies, the primary prevention. It focuses on health education on personal hygiene, avoidance of close skin to skin contact with the infested person, improvement of the living condition and reduction of overcrowding, regular washing of clothes, bedding, and towels, community awareness in schools, hostel, and institutions, proper cleanliness and body care, and frequent change of underclothing and beddings. The secondary prevention aims at early diagnosis through clinical examination, prompt treatment of confirmed cases, simultaneously the treatment of household and close contact, screening in high risk and institutional setting, and active case finding during outbreaks. The tertiary prevention focuses on treatment of complications, which is secondary bacterial infection and eczemas, management of crusted scabies, prevention of recurrence through follow-up, counseling to reduce stigma and improve compliance, and rehabilitation of patients with severe skin damage. The prevention measures which should be taken during scabies outbreak, the mass treatment program that use topical permethrin or oral ivermectin. We will look at the mass treatment later. There is no vaccine available for scabies. The simultaneous treatment of all close contact is recommended even if they show no symptoms of infection to reduce the rate of recurrence. Families are treated all at the same time. Asymptomatic infection is relatively common. Rooms used by those with crusted scabies requires thorough cleaning. Maintain a high level of suspicion if patient present with undiagnosed skin rash. Disease control, which basically focuses on mass drug administration strategies which have the potential to substantially reduce the prevalence of scabies with concomitant reductions in impetigo. In 2019, WHO convened an informal consultation of global experts to review available data and develop recommendation on strategies for global and country level control. The expert agrees that there is a convincing evidence that MDA, that is mass drug administration, can be highly effective in places where the prevalence is greater than 10% or more, but the evidence for its effectiveness in places where the prevalence is less clear. The current recommendation is that 2 doses of ivermectin at the dose of 200 microgram per kg should be administered, and a topical agent such as permethrin 5% cream should be given when ivermectin is contraindicated or not available. Coming to the epidemiology or the global burden of the scabies, at least 200 million people worldwide suffer from scabies at any one time. An estimated 5 to 50% of the children in resource poor areas are affected by scabies. Globally, it is estimated to affect more than 200 million people at any time and more than 400 million people cumulatively every year. Recurrent infestations are common. The sheer burden of scabies infestation and its complication poses a major cost on healthcare system. The cases are sporadic in high-income countries, yet outbreaks in high health institutions and vulnerable communities contribute to the significant economic loss and cost in national health services. The WHO response in 2017, scabies and other ectoparasites were included as neglected tropical disease by the WHO in response to requests from member state and the recommendations for the WHO strategic and technical advisory for the group for entities. The WHO 2030 global targets for scabies include countries to incorporate scabies management in the universal health coverage package of the care, and countries should conduct MDA, that is mass drug administration intervention in endemic areas, and the endemic area is defined as area where the prevalence of scabies is 10% or greater than 10%. The recent advances. This is an article which state that the spinosad at 0.9% in the treatment of scabies. The efficacy results from 2 multi-center randomized double-blind vehicle control trials. So, spinosad is basically an insecticide derived from the fermentation of a soil actinobacterium, which shows promise as a potential treatment agent. So the objective of this study was the combined result from true clinical controlled studies who were used to evaluate the efficacy of 0.9% spinosad topical suspension in the eradication of scabies. So each study included index subjects, the youngest household member with active scabies, and up to 5 other members in each household. The subject, they applied 0.9% spinosad or vehicle 1. Primary efficacy was the percentage of index subject with complete cure on day 28. The results, the spinosad at 0.9% is not equivalent to vehicle in the percentage of index subject achieving complete cure on day 28, 78.1% versus 39.6% respectively. Additional efficacy analysis confirmed that the consistent treatment effect of 0.9% spinosad. There was no safety signal observed. They concluded the spinosad at 0.9% performed better than the vehicle in the treatment of scabies in these studies of subject of 4 years of age or older following one application of study drug. Coming to the multiple choice question, a 7-year-old boy present with the intense itching, which worsens at night. Similar symptoms are present in siblings. Burrows are seen in interdigital space. The most important public health intervention is A. Treat only the index case. B. Prescribe the antihistamines to family. C. Treat to all close contacts simultaneously. D. Improve nutrition only. E. Isolate the child for 6 weeks.
C.
Yes, C is the right answer. The second MCQ is a 65-year-old bedridden patient developed thick crusted lesion with minimal itching. This form of scabies is particularly dangerous because A. It resolves spontaneously. B. It is drug resistant. C. It causes systematic infections directly. D. It spreads only sexually. E. It is a high. The disease has a very high mite load.
E.
Yes, E is the right answer, as the scenario is for immunocompromised individual and it is a crusted or Norwegian type of scabies and it has a very high mite load. The third MCQ is in a community with the high prevalence of scabies, which complication has the greatest long-term health impact? A. Skin pigmentation. B. Impetigo leading to glomerulonephritis. C. Sleep disturbance. D. Social stigma. E. Allergic dermatitis.
B.
Yes, B is
D.
the right. Yes, B is the right answer. The most common complications of scabies are the secondary bacterial infections like impetigo and cellulitis, and which can further lead to the post-streptococcal glomerulonephritis. The fourth MCQ is of health worker treating scabies cases in a prison, focuses on washing clothes and bedding. This measure mainly interrupts which link of transmission? A. Agent. B. Host. C. Reservoir. D. Environment. E. Vector. The right answer is D, environment. The fifth MCQ is a cost-effective analysis compared individual case treatment versus mass drug administration in a highly endemic area. MDR shows high upfront cost but lower long-term expenditure. Which epidemiological characteristic of scabies makes mass drug administration a suitable control strategy in endemic communities? A, the high case fatality rate. B, long incubation period. C, presence of asymptomatic carriers. D, vector-borne transmission. E, availability of vaccine.
C.
No, the right answer is C, the presence of asymptomatic carriers. The scabies has no vector. The sixth MCQ is which statement best explain why scabies is included among the neglected tropical disease? A, lack of diagnostic test. B, absence of effective drugs. C, high epidemic potential. D, disproportionate impact on marginalized population. E, zoonotic transmission. The right
A.
answer, the right answer is D. It has a disproportionate impact on marginalized population. The seventh MCQ is which indicator best reflects the burden of scabies as a public health problem rather than just a clinical condition? A, the number of burrows present per patient. B, intensity of itching. C, rate of secondary bacterial infection. D, type of mite. E, duration of treatment.
Alpha.
A.
No, the right
C.
answer is C, because scabies can lead to the secondary bacterial infection like impetigo and cellulitis, and it can further lead to, it has an effect on heart and which it can lead to myocarditis, and in kidneys it can lead to the post-streptococcal glomerulonephritis. So that is why. The eighth MCQ in a scabies control program, the treatment coverage is high, but reinfestation rates remain significant. The most likely missed intervention is A, repeat dosing. B, contact tracing and treatment. C, use of antibiotics. D, hospital referral. And E, laboratory confirmation.
B.
C.
Yes, B is the right answer because contact tracing and treatment is missing. So the infestation rate is high. A policymaker argues that the scabies should not be prioritized because it rarely causes death. Which arguments best support the prioritization from a public health perspective? A. Scabies lead to the severe downstream morbidity. Scabies is cosmetically disfiguring. Scabies spread rapidly. Treatment is inexpensive and it affects all age groups.
D.
No, the right answer is A, as we have already discussed about the complications. So it basically leads to the severe downstream morbidity. The last MCQ is how a health system decided to integrate scabies control into the primary healthcare rather than vertical program. The strongest rationale is A, reduced training needs, B, lower diagnostic accuracy required, C, sustainability and community reach, easier drug procurement, and the E is less monitoring is required. The right answer is C, sustainability and community reach. This is the key to MCQs. These are the references, and this is the official YouTube channel of the Institute of Public Health, where the recording of this presentation will be uploaded. And thank you for your patient listening.
Thank you so much, Dr. Ayesha. It was a very good presentation.
Thank you, Dr. Amna.